from passing through. It creates solid barriers. So physical barriers are always a good idea as far as trying to enhance medication safety. Okay, so now that we've talked about facilities, we're going to change gears a little bit and talk about technology and how that can improve medication. So when we look at technology, the ones we're going to talk about today, at least in brief, are going to be CPOE, or computerized prescriber order entry. We're going to talk about electronic health records. And CPOE is definitely a component of EHRs or EMRs, however you want to style it, either electronic health record or electronic medical record. Even though it's a component, there are different benefits, and so we're going to treat them a little bit separately here. Barcode technology administered in multiple different ways. We'll talk about pharmacy carousel systems. There's lots of other things too. There's robots, there's packagers, etc. But we're gonna use the carousel as our example for those dispensing technologies. There's smart pumps, and we're not going to really dive into smart pumps here. Basically, IV pumps that have guardrails for medications and prevent overdosing or underdosing of drugs, and also those pumps that tie back to electronic health records. So there's lots of advantages. And then last, and probably the most recent, not necessarily recent innovation, but recent required innovation, so to speak, is the compounding electronic workflow systems such as DoseEdge and MedKeeper and the like. CPOE is a wonderful thing. It's very hard for me to remember what life was like before CPOE. Essentially, the way this used to look, and you'll probably never see a pharmacy like this again, at least in a hospital. You would have a physician actually write medication orders on paper. That would be faxed to the pharmacy, and then the pharmacist would manually enter it into some sort of electronic database, because that was also before we had electronic health records as well. And so in that world, there was this extra step. So that's the reason whenever we look at the MedUse processor system, we see prescribing and transcribing as two separate steps. With e-prescribing becoming more and more in vogue in the community, even in community and retail pharmacy, we see this merging into a single step. And as a result, you always want to decrease the number of steps, because that's the less handoffs, the less likelihood of error. And even though whenever we looked at the number of errors that occur in the transcribing step as less than those that occur in the other steps, particularly prescribing, there's definitely an advantage to reducing the number of errors that occur and getting closer to zero. The other thing that's great about CPOE is that it reduced pharmacist workload. And so now that you have these, what used to be so-called staff pharmacists, now that they're not basically very highly educated secretaries and entering written orders into electronic databases, they now have a lot of free time. And so really between 2007 to present, you're seeing these staff pharmacists that used to be considered a different tier from our so-called clinical pharmacists. You see them being more and more trained in clinical activities. And so now they're becoming, you have kind of this new hybrid model where all pharmacists are performing some degree in this merged prescribing transcribing step, but are also have a heightened involvement in the monitoring step, which used to be the most neglected step of the MedUse process, and sometimes still is. And so consequently, pharmacists have a lot more time to spend in this monitoring step and assuring that medications are correct. So really, CPOE is probably the best thing to happen to pharmacy. Pulling away from specifically CPOE and looking at electronic health records or electronic medical records, however you want to style it, and we look at the difference in how EHRs have progressed from 2007 to 2013, we see a massive increase in the utilization of EMR. Greater than 30% of all hospitals surveyed use a complete electronic medical record. And this was in 2013. I'd be shocked to find that this number hasn't broached greater than 50% by now. We see that most pharmacists tend to have a complete view of electronic medical records, so they can view labs, they can view progress notes, etc. We see that about 70% of electronic health records have complete clinical documentation, meaning that there is a way for pharmacists to be able to document. We can see progress notes, and then we can also see adjustments to therapy in the background as well. And then now, and probably the most impressive part of this slide, is that 80% of those hospitals that do have a complete electronic health record, pharmacists actively document their in the form of recommendations, in the form of SOAP notes, in the form of provision of care. And so really this enhancement is probably one of the greatest things to happen in healthcare, because now we can take care of patients without having to sit and wait for the chart one at a time. We're able to do this from a team approach. So the accessibility of information has really been a game changer for healthcare as a whole, and I think it's just going to continue. Barcode technology was one of the first innovations to be considered by healthcare, mostly because it's one of those things that's adaptable from industry to industry. And so if we consider, barcoding and how it's been used in retail, not retail pharmacy, but, retail clothing, retail grocery, and the like, it really was kind of interesting that pharmacy, or that the healthcare industry as a whole, was kind of a late comer to that bandwagon. Here you see an automated compounder with a barcode technology depicted there, but there's so many can be implemented. So barcodes can be implemented using, most commonly, and probably the biggest bang for a buck, is on medication administration. We also see TechCheck utilized, where technicians will refill automated dispensing cabinets using barcode technology. Carousels, which we'll talk about that in just a sec, are also a big user. And then, of course, the previous example, TPN compounder. So if we look at barcode technology implemented in a 735-bed hospital, this is one of the first barcode studies done, and this is at the dispensing level, not necessarily at the pharmacy level. So we see an error rate reduced from 0.88 to 0.61, and then the potential adverse drug events that likely were to occur from 0.19 to 0.07. And those may seem like such tiny numbers, but if you extrapolate that out to 20,000 patients in a month, which is probably what the 735-bed hospital got to, there really is just a huge impact at that individual patient level. In general, barcode is just considered so reliable. I mean, really, barring the human error component of this, your error rate is 1 in 10 million. And it's hard to find anything else that's that accurate. One of the more recent innovations that's finally being embraced, and personally I have mixed feelings on this, is automated sterile compounding workflows. These workflows really are designed to decrease the likelihood of sterile compounding errors. The product on the left is an element. It's not the entire product, but it's an element from Baxidosage, and the product on the right is BD Cato. What's interesting is both products can either use a scale system, a camera system, or both. And so we actually program in specific gravities and appropriate doses for everything that we compound. So each drug's specific gravity is actually pre-programmed so that we can weigh it down to 0.01 gram accuracy. A recent analysis, and this particular workflow analysis, I believe, was done of Baxidosage, showed what an automated system captured and then what the automated system missed and then the pharmacist captured. Unfortunately, what this doesn't show is what was missed by both. And obviously, if we knew it was missed by both, then it would probably mean that we have a better system in place. So we have an unknown amount of errors that went out. The blue columns listed here are those errors captured, or that percent of the total 100% of errors captured by the automated system. And then the orange bar is going to be those captured by the pharmacist. And so it's very obvious that there are some, like, and we're talking in the elements of like 0.1% or a little bit more, 0.1% to 1%. Variance in things that were missed by the automated system that were then captured by the pharmacist. If you look at wrong diluent, wrong drug, and the like. Where we really see the difference is wrong volume being captured by the pharmacist. And I'm not sure where this comes from. I'm wondering if it has to do with the accuracy of the systems we have in place. There's also the potential for expired product, and then there was this category of other that included various things like barcode failures and the like. So it's very interesting that I think the big takeaway from this slide is that the automated sterile workflows really are a powerful tool to assure that we capture a large number of errors, but it is certainly not a replacement for a pharmacist performing quality check. Carousels. The carousel shown here is actually from Texas Health Harris Methodist Fort Worth. The carousel shown is quite large, but what's interesting is this particular carousel, which is a product of Omnicell, extends roughly 17 feet into the ceiling and then an additional 4 feet into the ground. And there's actually a trap door out of camera view here that you can go down into the bottom to collect all the medications that have fallen from the bins in this carousel. The carousel itself is typically, most carousels are going to be networked to your electronic health record so that when a new order processes, it comes across directly. There's also the opportunity to put in manual entry for things to be removed, or manual inventories or manual returns as well. You'll notice that there's a label printer located in between the two carousels, one printer for each carousel. And these queues are usually put on automatic, so they'll automatically dispense and print. You can't see in frame here, but there is a barcode scanner. You may be able to see it in the picture on the right, but there is a barcode scanner that's used to scan the label and then scan the product. Older carousels, you actually scanned the bin rather than the product itself, but it is ideal to pre-program all of the national drug codes, the NDCs, barcodes into your system so that they match up. What's amazing about carousel systems is they really do improve the accuracy of filling and dispensing. And so whenever we look at refill errors and percent of dispensing errors total, you see a significant decrease from baseline to 6 months. And you'll notice, I mean, the pharmacy obviously already has a low error rate, and that's where we would want to be, but really getting to that closer to zero, it's very impressive how low the percent of filling errors on the ADC refills happened at 6 months in this particular study. So if you look at the learning curve that we have to deal with, if you look at, we're still looking at the same slides as far as the baseline and the 6 months. So the blue and the gray bars are still the same, but there's this new bar that's at 6 weeks, and you'll see that error rates went up for first dose dispensing errors, up considerably actually. And so the important thing to know here is that anytime you implement something new, even if it is something that is designed to improve patient safety, your risk of errors generally increases considerably above where it was before the new process was implemented. And that's because of the distraction factor, and learning the new process and designing the new process. And so it's really important. I mean, this highlights the importance of educating staff before implementing new technology, working with your vendor to ensure that that much of the as many of the kinks as possible are worked out before implementation day, and also highlights the importance of being ready to go on the day of implementation. Because even with all those factors, this facility in this study had higher error rates at 6 weeks. So when we take all those, types of improvements, I wanted to pictorially show you where those improvements bridge and why we pursue a multi-solution approach, especially